Good morning, everybody. I would like to open the section of Hepato-Biliary and Pancreatic Surgery in ELSA 2020 Virtual Congress. Welcome to all the speakers. And first of all, I would like to introduce the first topic. I would like to introduce Professor Brian Gore. He is presently the Senior Consultant and Clinical Professor at Singapore General Hospital. He is also the Director of Solid Organ Transplant at the Sing Health Duke NUS Transplant Center. He is highly experienced subspecialty surgeons, having performed over 1,200 major HPP transplant surgeries since become a board certified surgeon. He is a pioneer in robotic HPP surgery in Southeast Asia and has performed over 500 major laparoscopic and robotic HPP transplant surgeries, including over 100 robotic surgery to date. He has held over 50 million in grant funding and has over 260 PubMed index articles. He has a high index of 46 and his work has been cited over 6,300 times. I would like to invite Professor Brian Gore.
Okay, thank you very much. I can't start my video. I'll just check.
It's okay.
Okay, so I'm just going to share with you our experience in SGH with the adoption of MIH. I have the following declarations. So the content of my talk will be, I'll just look at the status of MIH in Singapore. We will concentrate on our experience in SGH, share some of my personal learning experience and conclude. So this was a review in Singapore from 4 public institutions and shows the growth of MIH in Singapore. We started in 2006, very small numbers. Presently, the number has grown exponentially over the last few years. This is the breakdown of cases in our country. So 4 centers participated, and this is SGH. At that time, that was 2018. This is the Iwate criteria, which we are all familiar with, and it actually shows us the difficulty of MIH. And basically, when one wants to adopt MIH, one has to take into account factors such as the location of tumor. These are the difficult locations, segment 4A, 7, and 8. The extent of resection, whether you're doing a small resection or a full hemihepatectomy. And obviously, things like cirrhosis and liver function is also important. Location of the tumor close to major vessels. Size is obviously also another important factor. So some background about SGH. We presently do about 200 liver resections per year, 100 pancreatic surgeries, 30 biliary operations, and only about 10 to 15 liver transplants. We started MIS in 2006, but only since 2012 did some of us systematically pushed the field of MIS. And presently, we have done about 600 liver resections and slightly over 200 pancreatic resections. So this is the chart showing the growth of MIH in SGH. We started with very small numbers, and since 2012, then there's a major jump in the number of cases. And presently, slightly over half of the cases are major liver resections. So we have shared our learning experience in the literature over the last few years. If you're interested, you can look at these articles. But in this talk, I will just talk our experience with the first 600 cases we did till 2019. So of these, 96% were totally lab or robotic. Initially, we did some hand assist and lab assist cases. So these are the cases. The outcome. About 40% had previous abdominal surgery, 8% were repeat liver resections, majority were ASA 1 or 2, and about 80% were for cancer. In terms of the type of resection, 1/4 were major resections, 5% were multiple resections, and about 40% of our cases were in a difficult location. 1/4 of our cases had liver cirrhosis. The open conversion rate was about 8%. Operating time was about 4 hours plus. In terms of hospital stay, the median stay was about 4 days. Overall major morbidity was 5.5%, 1.7% of patients had reoperation, and the 90-day in-hospital mortality was 1%. About 40% of cases were high or expert level based on the Iwate score. So we broke down these 600 cases to 6 time periods of 100 cases, and we looked at the trend. What we can see is over time, our patients got older. We perform more and more totally MIS, so no more lap assists or less hand assists. More and more patients had previous abdominal surgery, and more patients had repeat liver resection. More and more patients also had concomitant other major surgeries such as colectomy. There were more and more major resections. However, liver cirrhosis of note actually decreased. The open conversion rate decreased from 18% in our first 100 patients to only 1% in our latest 100 patients. In terms of transfusion rate, this also decreased from 19% to 7% of patients. Blood loss decreased, and the use of Pringle maneuver actually increased. In terms of major morbidity and mortality, this remains constant. In terms of the Iwate difficulty score, we also started to perform more and more difficult cases, and there were a high proportion of high or expert level cases in the latest group. So from this data, we can see that although we expanded the indications of MIH to older patients and more complex resections, although there was a decreased frequency of liver cirrhosis, this was associated expectedly with longer operation time. But importantly, open conversion rate, blood loss, and blood transfusion rate decreased with experience. Next, we look at the open conversion and the outcomes. So we look at factors which determine open conversion, and looking at all these common factors: previous liver operation, cancer, tumor size, concomitant surgery, major resection, tumor location. These were all not significant. The only significant factor was presence of liver cirrhosis and our experience. So if you have the first 100 cases, the conversion was very high, and subsequently it dropped a lot. So from this analysis, we also look at the outcome of open conversion. And as you can see, expectedly, transfusion rate was higher in the open conversion group, 46% versus 13%. Blood loss was higher, and hospital stay was longer. Expectedly, complication rate was also higher in the open conversion group. And importantly, mortality was actually higher. Multivariate analysis showed the same thing. Institution experience and cirrhosis were the only predictors of open conversion. And of the 4 90-day mortalities, all 4 had liver cirrhosis. And 3 were actually technically related to intraoperative blood loss, of which 2 required open conversion. One of this mortality, the patient had uncomplicated surgery, but due to social issues, he stayed in the hospital a long time and developed pneumonia. So in this experience, we found that MIH can be adopted safely, but caution should be applied, especially during the early experience when operating on patients with cirrhosis. Major hepatectomy. This is our recent publication of the first 120 cases. I'm just going to run through briefly, but about 70 cases are what we call conventional major, more than 3 segments, and the rest were right anterior or right posterior sectionectomies. Looking through the data, I'm going to skip this, but importantly, about a quarter of patients similarly had cirrhosis, and open conversion rate was 8%. Pringle's maneuver is used in more than half the patients, and 1/3 of patients had blood transfusion for major hepatectomy. In terms of complication, major morbidity occurred in 7.5% of patients, reoperation in 2.5%, and the 90-day mortality was 2.5%. Next, I'll just look at the learning experience. So my personal learning experience, basically, I look at the first 200 cases I did till 2019, and I classified them into groups of 50 patients. And similar to the institution experience, you see more cases of totally MIS. Patients got a higher ASA score, means they got older and sicker. And we did more complicated procedures, such as more multiple tumors, more traditional major. However, other outcomes remain similar. Conversion rate was 6.5%, decreased from 12% in my first 50 to 4%. Operating time was stable, and Iwate difficulty score was stable. So when we did a CUSUM analysis, basically in terms of blood loss, blood transfusion, operation time, post-operative stay, all these showed that the CUSUM learning curve was about 65 cases. Morbidity remained constant. So in my experience with the MIS, whereby 47% of cases were higher expert level, 65 cases were needed to optimize outcomes in terms of this outcome. So after this learning curve, what you can see is that basically complicated cases can be done by MIS, including repeat liver resection. So 46 cases of repeat liver resection, gallbladder cancer, 18 cases in my experience, actually tumors more than 10 centimeter. You can also do diaphragm and IVC resection and caudate lobe resection. So this is some of the cases I've tried MIS. So very big tumors, you can do a right hepatectomy and extract them to a lower midline. Similarly, very big tumor in the left lobe requiring an extended left hepatectomy again can be done by MIS once you have gained enough experience. This is some of our papers we showed looking at oncological outcomes and other things. So this is a paper showing repeat liver resection, lap versus open. Again, repeat resection had a shorter length of stay but longer op time. So I'm coming to the end of my talk and I'm going to conclude here. So our initial experience in SGH showed that MIH can be adopted safely. Surgeons should adopt a stepwise approach when adopting these procedures, taking into account the difficulty of these procedures and their experience, especially in the presence of cirrhosis. MIH can be expanded safely to highly complicated cases. And the individual learning curve for MIH of all difficulties was about 65 cases. Thank you.
Thank you, Professor Gore, for very interesting experience from Singapore. I would like to introduce the next speaker. Our next speaker will be Dr. Chung Ngai Tang from Pamela Youth Nedazol Eastern Hospital, Hong Kong. He is the Chief of Surgery and the Director of Minimal Access Surgery Training Center at Pamela Youth Nedazol Eastern Hospital, Hong Kong, China. Dr. Tang specialized in SPP surgery and general surgery. He is the first qualified robotic general surgeon in Hong Kong and the pioneer of MAS, Hepato-Biliary surgery in Hong Kong. Dr. Tang has accumulated more than 800 cases of robotic assisted HPP and general surgery since 2009. He published extensive on MAS SPP surgery with more than 100 original publications in peer-reviewed journal book chapter. He delivered about 200 invited lectures on laparoscopic and robotic surgery, SPP surgery in local and international symposia. He founded the Hong Kong Society of Robotic Surgery in 2014, and he is also the past president of Clinical Robotic Surgery Association and currently president of Asia Pacific Association of Robotic Surgeons. I would like to invite Professor C.N. Tang from Hong Kong. Hello? I'm sorry that Professor Tang is not around, so we will skip to the next speaker. I would like to introduce Professor Goro Honda from New Tokyo Hospital, Japan. He was born in Kumamoto, Japan, and he's graduated from Kumamoto University. He obtained his PhD at Kyoto University School of Medicine, and he completed his training with fellowships at the Kyoto University Hospital in GI surgery. He published a lot of articles regarding laparoscopic HPP surgery and pancreatic cancer treatment. Since he was a chief surgeon of Tokyo Metropolitan Cancer and Infectious Diseases Center, Komagome Hospital. Currently, he is the chief director of Department of GI Surgery, New Tokyo Hospital. He is one of the leading surgeons of HPP surgery and laparoscopic surgery in Japan. I would like to invite Professor Goro Honda.
Okay, thank you, Tran. I will start my talk. Good morning, everybody. Today I will show you our standard technique for laparoscopic left hemihepatectomy. Just a moment. Okay, I will start my talk. Can you see? Okay.
Yes.
Yeah. I describe our latest procedure of laparoscopic left hemihepatectomy by using an Arrantius first approach in a laparoscopic cold dorsal view. I will describe about the Arrantius first approach. This is left lateral section in a cold dorsal view. And after mobilizing the left lobe lateral section, by flipping the lateral section, we can see the Spiegel lobe here and segment 4. And this is umbilical plate. And the root of the left hepatic vein can be seen here. And Arrantius duct is running here. I'm sure the lesser sac covered Spiegel lobe here, but we can see through this thin membrane. And first, we open this lesion, and sometimes we can see that behind the posterior aspect of the middle hepatic vein here. And after that, we move to the hepatic haram side and dissect the left Grissonian pedicle here and encircle like this. And it's easy and quick isolation of the left Grisson because already we make the big cavity around behind this Grisson already. So this is safe and easy. And after that, the dissection of the left Grisson is very easy and quick. And also the safe for the right bile duct. If maybe you know sometimes the right posterior bile duct joining here to the left bile duct. However, if we cut just above the bifurcation of the Arrantius duct here, it's safe. It's safe. It's always safe. And the Arrantius duct can become one of the landmark of the appropriate plane of the left hemihepatectomy because this is middle hepatic vein and the demarcation line is here. Continuously these 3 landmarks, we can identify the appropriate plane for the left hemihepatectomy. This is the after dissection, we can see like this demarcation line is here, Arrantius duct is here, and the middle hepatic vein is here. This is a final view. I will show you the case, one case. The 74-year-old man with HCV viral infection, and he has HCC of 4 centimeter located adjacent to the U portion here. This is, and his liver function is normal. And this is the port placement, and main surgeon stand the patient right side. And actually in this surgery, I was the assistant surgeon and I stand it on the patient left side. And Pringle tourniquet is placed here. And this is the first we cut the falcial ligament and round ligament and go to the cranial side, and the crown ligament was divided, and the triangle ligament also divided. And the root of the middle and left hepatic vein was exposed like this. And I identified a crotch between the both hepatic veins. And by open the lesser omentum small, in just small hole, the tourniquet system for the Pringles maneuver was placed like this. And by upturning the left lateral sector, the first we are identifying the Lynch's duct. We can identify a Lynch's duct here, and this is the root of the left hepatic vein. And by cutting the membrane just above the Lynch's duct is here, and the ablating the liver parenchyma, we can see the root side of the middle hepatic vein here. And here, this is the left Grison pedicle. And after making the big space behind the left Grison pedicle, we move to the hepatic hilum side. And this is one of the small branch to the segment 4 from the hilum plate. This is clipped and cut and expose the right and posterior aspect of the left Grison pedicle and easily isolate the left pedicle like this and taped just beneath, just above the bifurcation of the Lynch's duct. This is very important. And by clamping this pedicle, we can identify the demarcation line on the liver surface and marked by electric cautery. And recently, we almost always spare the gallbladder, and a little bit left side we cut. And after that, by inserting the linear stapler, the most lateral side trocar, the easily divided like this. Very safe because big space is already spared behind the right Grison. After that, only the surface portion was dissected by the harmonic scalpel. And up to the most cranial side. And sometimes we cut the most edge side because this is very easy to identify the good plane in a bird view. I mean, we should open the liver like opening a book. It's very important. And after that, we flip up the left lobe, and we are exposing the middle hepatic vein from the root side like this. And the assistant is me using the harmonic like this. And that's why the surgery is very quick. And sometimes we confirm the demarcation line on the liver surface, and we decide which branch should be cut, which branch should be spared. It's easy because the liver parenchyma was opened from the coda side, like a book, opening the book. So this is easy to determine which branch should be cut. This branch should be cut. we decided, and encircle and clip and cut. As I said, the demarcation line on the liver surface and a laryngeal duct and the middle hepatic vein trunk is the 3 landmarks to make appropriate cutting plane. And as you can see, this plane is intersegmental plane, so the very quickly cut it like this. And this is the final branch from the medial sector. And I didn't isolate and cut. And we are going to the root of the middle and left hepatic vein, like this. And in an intersegmental plane, there is no Grissonian branches, so we can dissect quickly, like this. And just
Please
in case we
fast, Professor
hate,
Honda.
Yeah.
Please make it fast.
You cannot see?
Please make it fast. Time is up.
Already? Okay, we cut and finished. 10 minutes? No? Now this is the operative time was less than 2 hours, and the patient has the postoperative course was good. This is my conclusion. The Atlantis first approach provides the followings: the easy quick isolation of the left grisson, and the division of the left grisson is very easy and safe for the right bile duct, and on the landmarks for an appropriate plane. The Atlantis first approach is very useful for the laparoscopic surgery. Thank you for your kind attention. Thank you very much.
Thank you, Professor Gore Honda. We will back to the question and answer later. So I would like to introduce our chairman, Professor Ho Sun Han from Hong Kong, Seoul National University, Bundang, Korea. So please share the session.
Yes, thank you, Dr. Tuan. I was trying to connect, but because I don't have any link to Zoom, so that's why I take time. But I listened to the Dr. Brian Go's speech. But I listened, but I cannot enter this room. Thank you very much for chair the session. And then I will chair the next session. The next session is Dr. Yoo-Seok Yoon. The title is How I Stabilize Technique for Laparoscopic Pancreatic Duodenectomy. Dr. Yoon is my colleague, and he graduated from Seoul National University College of Medicine in 1997 and working with me in Seoul National University Bundang Hospital. And he is very interested in the laparoscopic surgery, including pancreatic duodenectomy and distal pancreatomy and biliary surgery as well. So he's one of the leading surgeons in Korea and Asia and the world as well. Dr. Yoon, please start. Dr. Yoon, yes. Okay.
Everyone, I'm Yoo-Seok Yoon from Seoul National University, Bundang Hospital. First of all, I would like to thank the organizing committee for giving an opportunity to present in ELSA virtual meeting. Today, I'll talk about how I stabilize technique for laparoscopic pancreatic duodenectomy. The number of published reports on laparoscopy is annually increasing. Many case control studies, meta-analysis, and some RCT show that laparoscopy is similar to open PD in terms of complications and survival outcomes. However, recent RCT showed contrary results. This trial was prematurely terminated due to high mortality rate in the laparoscope group. In this trial, participating surgeons had experience of at least 20 laparoscopic cases. The authors conclude that experience, learning curve, and actual volume might have influenced for outcomes. One of the major hurdles of laparoscopy is a long learning curve. Recently, we evaluated our learning curve for surgical failure using risk-adjusted custom analysis. The active failure rate decreased after first 60 cases and stabilized after case 84. When you take a look at published literatures, minimum cases for stable operation ranged from 30 to 56 cases. A recent study from Korea reported interesting results showing how important training is in shortening the long learning curve. Left figure shows the learning curve of the first generation surgeon. Surgical failure decreased after case 57 and stabilized after case 180. Right figure shows the learning curve of second generation surgeon who received the training from the first generation surgeon. Here you can see his training period. Surprisingly, the surgical failure decreased after only case 21. These results suggest that training and education are essential in shortening the long learning curve and decreasing unfavorable outcomes in the early period of the learning curve. In this viewpoint, I will talk about the three topics based on lessons from my learning curve. First, I will talk about patient position and trocar location. I prefer lithotomy position. This position provides three compartments for surgeon, assistant, and scopist. Their locations are changed at the time of anaesmosis. Most procedures are performed in reverse tenable position, and it is changed into flat position when relieving tension is required for anaesmosis. Trocar position depends on surgeon's preference, but it is very important in facilitating the procedure. It takes a long time for surgeons to find out suitable trocar location. During resection, operator stands the right side of the patient and uses these trocars. During PJ anaesmosis, operator stands between two legs of patient, uses a left side trocar for a needle to be placed perpendicular to anaesmosis line. During CJ anaesmosis, operator stands in the left side of patient and uses the apical support. Second, I talk about tips to decrease the risk of intra and post-operative bleeding. Intraoperative bleeding occurs more frequently from the vein rather than from artery. Portal vein and SMV and their branches are common bleeding sites. Sometimes bleeding occurs from the coronary vein. It usually drains into portal vein or spread vein, behind it the common hepatic artery. Thus, we should be cautious not to give an injury to this vessel during lymph dissection around common hepatic artery. First, the jejunal branch is susceptible to injury during dissection of Unsen process. Therefore, recognition of the anatomical courses of these vessels is important to reduce the bleeding risk. Selection of proper clips for vessel ligation is also important in reducing the bleeding risk. For arterial ligation, femoral clip is good because it can give a gentle ligation of the artery without injury. Metal clips can give crushing injury to the artery, especially in patients with atherosclerosis. For vein, ligation with metallic clips followed by sealing with ligature can avoid the bleeding due to slip of clips. This technique is useful in dissection of portal vein and SMV. This video shows the tips for dissection from portal vein SMV, which is a difficult part of laparoscopy. Sealing the small branches using clips and ligature and safe. And tiny branch can be controlled with a ligature alone. During dissection around the first jejunal branch, dissection should be performed as close to the pancreas as possible. The sealing the branches along with the round tissue without prior isolation can avoid the troublesome bleeding. The branch was clipped and controlled using the ligature. This video shows my tips for lymph node dissection. During lymph node dissection, we should grasp connective tissue or lymphatic tissue around the lymph nodes, not the lymph node itself, to avoid node fracture and bleeding. To avoid is development arterial pseudoaneurysm, which is a cause of post-operative massive bleeding, anesthesia should be applied to on loose tissue between lymph node and artery, not on the arterial wall. And lymphatic or nerve tissue on artery should not removed aggressively. Finally, I will talk about tips to increase the degree of freedom during laparoscopic anaesmosis. Trocars should be placed for needle to be perpendicular to anaesmosis line. This trocar is good for PJ anaesmosis. However, if we use only one trocar for ductal to mucosa anaesmosis, it is very difficult to place our needle in 660 degree direction. Alternative use of multiple trocars is beneficial. This trocar is good for only in this range of anaesmosis. This trocar is good for this range of anaesmosis. This trocar is good for this range of anaesmosis. For pancreatic jejunostomy, operate stents between both legs of patient. This trocar is good for outer layer anaesmosis between the pancreas and pancreatic parenchyma and pseudomuscular layer of the jejunum. For 12 o'clock ductal to mucosa suture, using this trocar, needle is placed for out-in suture to jejunal opening, and using umbilical trocar or needle placed to in-out suture to pancreatic duct. For 9 o'clock mucosa suture, using this trocar, needle can be placed for in-out suture to pancreatic duct and out-in suture to jejunal opening. For 6 o'clock ductal to mucosa suture, using this umbilical port on needle placed for out-in suture to jejunal opening, and using this trocar, the in-out suture to pancreatic duct. In summary, proper patient position and trocar location can facilitate the laparoscopic procedure. To decrease the risk of interbleeding, anatomic course of coronary vein first jejunal branch should be well recognized. Sealing the small branches using clips plus ligature is useful in dissection of portal vein and SMV. Gentle handling of lymph nodes is required to avoid bleeding from lymph node fracture. To increase the degree of freedom for laparoscopic anaesmosis, trocars should be placed perpendicular to the anaesmosis line, and use of multiple trocars is useful to encompass the 660 degree anaesmosis. Thank you for your kind attention.
Dr. Young, thank you very much for your excellent lecture. So we will have a later discussion. Thank you. Just wait. And I'd like to introduce my co-chairperson, Dr. Tuan from Vietnam. And Dr. Tuan is the governor of endoscopy laparoscopy Asia from Vietnam. and also he's a executive committee of Asia Pacific Hernia Society. He's a very active surgeon and very famous surgeon in Asia and the world. He will speak about lymph node dissection in laparoscopic pancreatic duodenectomy for pancreas cancer. Dr. Tuan, would you please start?
Thank you, Professor Sosan Han, for your kind introduction. I would like to share with you the topic lymph node resection in laparoscopic PD for pancreatic cancer. As we all know that PD have a high mobility rate and mortality rate, and the patients at high volume hospital have a better outcome. The lab PD first reported by Gardner since 1994, but it's very slow development. But nowadays, there are more and more laparoscopic PD all over the world. But as Professor Yoon presentation, this is a very difficult procedure, most complicated one, and have a steep learning curve. The goals of surgery for pancreatic adenocarcinoma is an oncologic resection of the primary tumor and regional lymph node resection. I would focus on regional lymph node resection. This is the anatomy of lymph node around the head of the pancreas. This region is very complicated because there's a lot of vessels, as you see on Professor Yoon videos, especially around the hepatic hilum. And for the standard lymphadenectomy during pancreato-duodenectomy for pancreatic cancer, this is the consensus statement by the International Study Group on Pancreatic Surgery that a standard lymphadenectomy should include the lymph node station 5 and 6. 5 and 6 is around the pylorus and duodenum. Number station 8A, 12, 13, 17, and 14A and B. 13 and 17 groups is around the pancreatic head. So usually it is removed with the specimen. 14A and B is along the SMA, and 12, B, C, and A, and P is along the hepatic hilum. Should we do extended or a standard lymphadenectomy? And from the performance of an extended lymphadenectomy during PD in 4-RCT was proven no benefit and should not be performed. As you can see, this is the result of the 4-RCT comparing lymph node resection in standard and extended lymph node lymphadenectomy. And we can see that extended cases have a more lymph node in all of the RCT. But finally, the overall benefit was not proven. That's why we should not perform routinely. And as you can see, the extended will include 17, 16, 18. Another systemic review shows that extended PD is associated with greater lymph node harvest and fewer positive resection margin, but again, no significant survival benefit. And some increased delay gastric emptying in the postoperative course. The standard lymphadenectomy in PD should provide more than 15 lymph nodes. And the more lymph nodes we harvest, the patient have increased survival rate. The ratio of positive and total to total examined lymph node, that is the lymph node ratio, also play a role in the prediction of the survival. And if the lymph node ratio is more than 0.2, it has the patient have a bad prediction. This is a long-term result from by John Stoffer and Horacio Asbjorn from Mayo Clinic. And we all see that laparoscopic PD have a very good lymph node harvest and long-term survival comparable to open surgery. And this is, you can see on this table, laparoscopic PD have a more lymph node harvest than open surgery. This is another report from Kendrick, from many other surgeons. You can see the lymph node retrieved in laparoscopic surgery is usually more than 15. This is our experience. We start laparoscopic pancreatectomy around 10 years ago, and our experience improved by time. And this is a case with after lymphadenectomy. This is the SMA. This patient have replaced the hepatic artery from the SMA. This is a lymphadenectomy in this is a CBD. This is a hepatic artery. This is another case. This is the hepatic artery, CBD, up high to the liver hilum, the portal vein, and the SMV. Care should be taken. We should only do the lymphadenectomy on the right side of the SMA to prevent the severe diarrhea after the surgery. The most difficult part is the lymph node behind the portal vein. This is a P1 or P2. So with proper dissection, we can dissect from the lateral to medial and then medial to lateral to remove all of these station lymph node. This is another case after removal of all the lymph node. This patient have a lot of big lymph nodes around the liver hilum. And you can see that a lot of big lymph node has been removed. This is another case. To do the lymph node dissection along the SMA, somehow we have to retract the portal vein and the SMV. And we also use hemolock for artery and clips for vein is Professor Yoon. For conclusion, LPD is growing with comparable outcome to open surgery. Lymphadenectomy in LPD is technically feasible and comparable to open PD. A standard lymphadenectomy should be performed in LPD for pancreatic adenocarcinoma. Thank you for your attention.
Thank you very much, Dr. Tuan, for your excellent lecture. And as you can see in the video, the operation was very clear and very meticulous. Thank you very much for sharing your experience. I think Dr. Xian Tang is with us. Oh, Xian Tang is ready. So if you're okay, Dr. Tuan, I will introduce Dr. Xian Tang.
Yes.
Okay? Dr. Xian Tang, are you there, Xian Tang?
Can you hear me?
Yes, thank you, Dr. Xian Tang. Yeah, thank you for coming. I will introduce just briefly, if you're okay. Dr. Xiantang is the Chief of Surgery and Director of Minimal Access Surgery Training Center at Pamela Youth Nasal Eastern Hospital, Hong Kong. Xiantang is specializing in HP surgery, and he's first qualified robotic surgeon in Hong Kong and pioneer in minimal access surgery, HP surgery in Hong Kong. He has accumulated more than 800 cases robotic assisted HP surgery from 2009. He published so many good papers and also delivered more than 200 lectures for laparoscopic and robot assisted HP surgery. He's founder of the Hong Kong Society of Robotic Surgery in 2014, and he's also the past president of Clinical Robotic Surgery Association and current president of Asia Pacific Association of Robotic Surgeon. Today, he will talk about challenge of robotic hepatectomy. Dr. Xiantang, thank you very much. Please start.
Thank you very much. I'm so sorry I'm not able to join the initial part webinar. Nico. Share. Okay. Yes, sir. Let's see.
You should stop and share again. This is not the window of presentation.
Can you see my PowerPoint?
No, it's Zoom.
Can you see my PowerPoint?
No, you should stop and share again.
Share. Share. Igor. Share. Okay. Now. Can you see it?
Okay, it's fine. It's fine. Now you can start.
Okay, fine. Okay. Yeah, I can start now. I'm so sorry I'm not able to join your initial part of the webinar. My talk today would be challenges of robotic hepatectomy. Somebody said liver is a female organ, just like your beautiful lady at home. There are long lists of characteristics of liver, but I think the last two parts is really interesting. When liver doesn't work, everything goes wrong. Similar to your wife doesn't work, everything goes wrong in your house. After years and years of research, nobody really understands it. This is a picture captured about 100 years ago. This is a comic picture. This happened of the operation theater in year 2000. And I think there would be many similarities what we are doing right now. Surgeons are not next to the patient. Surgeons are basically control and doing surgery with fingers and feet on the pedals. And technology changes everything. And I think there's no exception for surgery. And but how of imagination is even more important, and which can get you everywhere. Imagination. The Vinci robotic system was introduced in 2000, and I think there would be a lot of obstacles when not just for surgeons who are using it to overcome technical hurdle, but this is also a challenge for international intuitive surgical international trying to popularize it in the market. But at the end, a trial is still a trial, and robot won't make him smarter. I think this is really crucial. I would consider robot just a surgical tool. And if you don't have sound knowledge about anatomy and also surgical technique, and robot can just make you more dangerous than smarter than doing surgery. And there are many startup difficulty seems to be important nowadays, not just in Hong Kong, but also in most parts of the world would be financial support. How can get the reimbursement from insurance? Teamwork is essential, and there's also very important to engage all the stakeholders, not just surgeons, but also nurses and anesthetists. In order to guarantee good outcome, you have to standardize your procedure and also provide training and portraiting to ensure service sustainability.
And this is a robotic hemihepatectomy. I just want to show very quickly what we can encounter. I think this is not really interesting. I will go for individualization before I move on to do the resection. And this is the right branch of the portal wing. And after control of right branch of portal wing, I will start mobilizing the right liver. And this is posterior dissection, separating the adrenal from the liver and mobilizing further. And I routinely put a pingo cam and just allow me to have info control. I think for normal liver, there's no issue. For a disease liver, you have to stick on intermittent pingo. I think hepatic wing nowadays would be so essential for you to go along it and then dissect it. And this is last part of the surgery, which is basically ligation and the stapling of the right hepatic wing. And this is another surgery I would like to show you would be the posterior sectionectomy. I think that would be very similar, control the info, and then mobilizing the liver, and then look at it, how the liver is mobilized. I usually put my patient in semi-lateral position, and then we can have a straight line of the right hepatic wing, and this is the line will guide your surgical transition. And I think I switch from ELSA, now using harmonic scalpel for all my cases, because I think you need to control the axis of transition. And if you rely on somebody using ELSA, you might have a bit of trouble. I think this is the right hepatic wing, carefully dissecting out until it is reaching the IVC. And this is what we are doing routinely nowadays. With pneumoperitoneum, I usually switch it to about 50 millimeter mercury, and also decrease the airway pressure to about 18 millimeter mercury. I think this is the way how we control the breathing from the hepatic wing. I think this is really standard nowadays. And this is last bit of resection and outline the right hepatic wing on the resection pane. This is another surgery what we can think about, because this is something good. This is a CAR scan tumor. This is something good because Robot can allow you to do anaesmosis, harvesting all the lympho important hepatitis, control the info, and then go for parenchymal transitions and control the margin and so and so. And once again, the hepatic wing would be so essential. And this is the last bit of transition. And after the resection of the right lobe together with the bile duct tumor, you still have to think about how to create anaesmosis. And this is how I perform the anaesmosis with the inside through DVD. And this is really facilitated. I think this is the most demanding part when you think about doing robotic surgery for CAR scan tumor. This is the stock price of intuitive surgical industry. I think you can see gradual coming up of the stock price because of the successful business of intuitive surgical, and all because of the increased number of cases using the robotic system. And a little bit more for robotic urology and also gynecology. But what seems to be impressive would be general surgery, which is the blue line, and rapidly increasing over the years. And this is my department of surgery. Over a period of about 10 years, we have done about 2,400 cases. And what's not really impressive in terms of number, but very healthy when look at this figure, and the number of cases performed across different specialties really fair and also healthy. And liver resections, I think this is team approach, and there will be many potential benefits. But what seems to be important, and whenever hepatectomy requiring BU and thyroid anaesmosis, and also difficult segment and major hepatectomy might make use of robot to overcome the technical hurdle. CAR scan tumor would be another potential area, and with the use of robot to facilitate the performance of surgery. And this is a database accumulated over a period of 10 years, and we have done altogether close to 400 cases of robotic hepatectomy. 89% would be malignant, mainly primary hepatoma followed by colorectal metastasis, cholangiocarcinoma, and also recurrent pyogenic cholangitis. And 24% major hepatectomy, about 120 cases would be major hepatectomy, mainly right hemi, left hemi, and also some extended hemihepatectomy. And 40% in different segments, and overall operating time slightly more than 3 hours, and a very small percentage of patients requiring open conversions, and complication may occur in about 12%, and there would be dysfunction of liver in 3 patients requiring a longer support in an intensive care unit, and mean hospital stay would be 8 days. Out of resection achieved in 92%, and there are 2 90-day mortalities, and accounting a figure of 0.5%. And I think this, and MC, and date back to about 2014, making use of it, we can see high percentage of major hepatectomy in UPMC. And similarly, when we're using robot and reported in 2014, and we can see more cases to be handled with located in posterior superior segments. And learning curve can also be decreased by 45 cases to 15 cases, according to the experience in NTUH. And survival for our data for primary hepatoma, short-term survival and long-term survival are not really compromised because of adoption of the robotic approach. And I think this is a recently published meta-analysis, and you can see close to about 487 robotic cases versus 902 patients in a post-op group. And there's not much difference in terms of post-op outcome. And the meta-analysis indicated robotic as well as laparoscopic display similar effectiveness and also safety in hepatectomy. And this is a paper, again, waiting for published and accepted, and with higher number of cases, 950 robotic versus 1,600 cases of laparoscopic. I think once again, the post-operative parameter are more or less the same, even though there are tendency of less blood loss and also long operative time for the robotic approach. This is Oracle consensus meeting 2014, and I think there are many achievements in that consensus meeting. Minor should be standard, major is still recommended, but we need to introduce it with caution. Robotic, we need a team, not a single surgeon sitting at console and doing it. We need instruments. I think the instrument at the moment is still far satisfactory compared to laparoscopy and also open surgery. The instrument largely for parenchymal, we are using CAM crushing, bipolar, small clips, hemolog, and so on. Sometimes use suction irrigator and vessel sealing. I think those are not really good. At the moment, I switch most of my cases from the bedside surgeon using ELSA to harmonic scalpel. I think this is the one, as long as you can achieve correct access of transaction, you can really achieve good control of hemostasis. And there are pretty limitations of the current instrumentation in robotic surgery. I think the increased bulkiness of robotic surgery and for the sake of dexterity, and this is still too big and apart from too expensive. And the second issue would be the access of camera, govern how you go for parenchymal transaction. So in order, whenever you are using the robot for not a straight line transaction, you might have a bit of difficulty in terms of how you are moving the instrument to achieve like segmentectomy, bisegmentectomy, not going for a straight line. And even though the multi-quadrant adaptation can be a bit improved with XI model, but this is not perfectly correct. And it will be a bit easy for open surgeon switching to robotic surgery, but experience MBS liver surgeon switching to robotic. I think the vision is pretty obvious. Once they accumulate experience in doing MAS hepatectomy and with all the technical skills and tricks, and switching to robotic platform, that means you have to relearn once again for all the surgical techniques. This is the development of robotic versus laparoscopic hepatectomy. I think the development is pretty rapid for laparoscopic one compared to robotic. And there are many issues, whether there will be hurdle of anatomy, cultural changes, training issue, ego aspects, or whether there will be cost issue. I think there are multifactorial. And this is the ELSA picture of the Council Man 2019. And I think laparoscopic, robotic, we are not enemy. We are basically using different kinds of surgical tools, respecting similar surgical principle and doing surgery. I think we can collaborate and then see whether we can do surgery in a better way. By comparing laparoscopic versus robotic, it's just like comparing a bicycle and a supercar like Lamborghini. It's not fair, and one vehicle has to be eliminated in the market. And somebody would favor bicycle, somebody would favor a supercar, depending so much whether it can afford it and whether it can handle it well. I think there will be situation you might have to think about switching from one vehicle to the other vehicle or vice versa. And this is somewhat very similar when you're doing laparoscopic and also robotic. Follow the same surgical principle and doing carefully, and then not really competing. We can adopt a more collaborative model, and by switching to laparoscopic or switching to robotic according to situation. I don't have the crystal ball to tell what will happen for robotic. I think there will be two very essential statements I would like to summarize my talk. Robotic hepatitis will prevail and become more prosperous, provided that there will be improved technology and also instrumentation. It's really hard to surpass laparoscopic hepatectomy if the price is persistently high. I think the price is high in US market, but this is also extremely high in the market outside US, almost double the price. And I think we can only hope for whether there would be future industry competition able to bring down the price and make it more affordable in the future in order to, we can talk about popularization. I think this is what I would like to share with you today. Thank you so much for your listening.
Thank you very much, Dr. Xian Tang. It's a very excellent lecture. So, as you mentioned, that the propagation of robotic hepatectomy is not so dramatic compared to laparoscopic surgery, but it is very admired that you are doing many robotic hepatectomy so well. So, congratulations.
Thank you.
So, because all presentation is over, so we may have some 10 minutes or 15 minutes to take and we can discuss. Because you are the last one, Dr. Xian Tang, so I will discuss laparoscopic hepatectomy and robotic hepatectomy with you and Dr. Gore Honda. So, Dr. Xian Tang, do you have experience laparoscopic hepatectomy?
Oh, yes.
I think.
Yeah, of course. I started my laparoscopic hepatectomy in 1998. I have done it for about 6-7 years. And I also performed laparoscopic PD since 2005 for 2-3 years. And then I switched to robotic hepatectomy PD since 2009. I think the issue for me is pretty unusual because I don't have any financial concern. So once I switch from laparoscopic to robotic, it would be really hard for me to switch back from robotic to laparoscopic. And because I don't need to pay for the expenses, and patient doesn't need to pay for the expenses. We got a very strong support from the hospital as well, from donation to support all the courses. So I think this is the situation right now, why I can accumulate so many robotic cases over a period of 10 years.
Yes, it is good for you that you can use without any worry about concern about the cost, so it's good. Anyway, although it's slow, there's several minimally invasive surgeon who is performing robotic hepatectomy. So I think there may be some advantage, although some disadvantage like you cannot use CUSA in the robot, but there are maybe some advantages. So I think still robotic surgery is another option. As you mentioned in the report by Giulianotti, it has benefit when you perform the anastomosis in liver surgery or clotting tumor or very difficult location. Yeah, thank you. So anyway, because Goro Honda is an expert in lap surgery, so I'd like to ask you a comment on robotic surgery, Dr. Goro Honda.
Thank you, Professor Han. Actually, I've never done by robotic approach. Maybe I think maybe as you know, I like CUSA, so but now we cannot use CUSA in the robotic approach. So I hope we can use the CUSA in the robotic surgery.
I think you are perfectly correct in the sense that most open surgeon and laparoscopic surgeon, they are using CUSA for parenchymal transition. I'm not saying harmonic scalpel can replace CUSA, but I'm just saying if your line of transition is a straight one, I think this is not a bad choice to think about harmonic scalpel. And this is really effective and hemostatic and also efficient instrument. And I'm not saying CUSA can be completely replaced, but I'm just saying harmonic scalpel can be a good alternative. And also respecting all the anatomical landmark, particularly hepatic.
And I have a question. And in the robotic surgery, the suction in CNS surgery, who use the suction device? Assistant? Suction?
Suction. Yes, but I think there would be a suction device. You can use it under your own control, but I never tried it myself. I would ask my bedside surgeon to use the suction device. I think this is also the concept of team approach. If you do think you sit at the console and you can control everything, it doesn't make sense. If you got another surgeon at the bedside, why you cannot cooperate with your bedside surgeon, working together? And the suction, the passing of instrument would be done by the bedside surgeon. In those days, when I start doing robotic hepatectomy, I also use the CUSA. But the CUSA will be controlled by bedside surgeon. I think this is okay, as long as the bedside surgeons understand what you are doing, but not entirely experience, and they might not able to appreciate very well about the line of transition, and that's the issue. So I switch a bit from using CUSA by the bedside surgeon to harmonic scalpel nowadays.
Yeah, I remember you used CUSA in a robotic surgery by Professor
That's a long time ago.
That's what team approach.
In almost 4 years, I switched almost completely to
because CUSA is one of the suction device, I think. So,
yeah. I understand very well. You got a very in-depth understanding about the use of CUSA and different kind of techniques using CUSA for coagulation, for suction, for hemostasis. Really perfect. I think this is really important, and there's a pressing need for intuitive surgical to think about inventing robotic CUSA. Inventing a robotic CUSA. I think this is really crucial. But at the end, even you got a CUSA, because we got two hands controlling the instrument on the left side, controlling the instrument on the right side. You got 2 foot, you got 2 feet, and stepping on different pedal. I think it is still fine, but I think you cannot completely replace the function of the bedside surgeon. The bedside surgeon is a very important and key stakeholder for whatever robotic surgery. And there will be many occasions like adverse event when somebody change it, they are not able to see it and injure the internal viscera when they change the robotic instrument. I think that can be entirely preventable if you've got experience to do the surgery. Guru, I think of laparoscopic and robotic surgery in your institution. I'm a bit surprised why you are not doing any robotic HPP operation.
Yeah,
your center is laparoscopic and robotic.
Yeah, actually in Japan, we did not, we have never been allowed to do the laparoscopic robotic liver surgery. So that's why. But I think that your old approach, I mean, assistant use the CUSA. That is one of the good way of the robotic surgery using the CHIM approach, as you say. That is very good. I believe very nice approach, I think. So if we can, I will try like that. It's one of the way, I think.
Thank you. Thank you.
Thank you very much. There are two the big surgeon in the minimally invasive surgery for pancreas, Dr. Tuan and Dr. Yun. So I'd like to ask the opinion of robotic PD to Dr. Yun and Dr. Tuan. Dr. Yun, would you say some your feeling about robotic PD in pancreas?
Yes. In my presentation, I already commented is a limited degree of freedom of this laparoscopic surgery. In terms of degree of freedom, robotic surgery is better. But for me, I started laparoscopic surgery after the experience of a lot of open cases, and it's another the laparoscopic surgery. So I was familiar with the laparoscopic surgery at the time. Robotic surgery was not common. But the situations are different for these young surgeons. Young surgeons is now robotic surgery is available, but when they start, there is a PD, there is a complicated procedure. The young surgeon can do robotic surgery. I think it can decrease the learning curve. But as this Sentang and Honda is already commented, is a problem is the price. Yeah. So when this hospital is robot is available, young surgeon want to start to do minimal invasive pancreatidurectomy. I think robotic surgery can be one option.
Thank you, Dr. Yun. And I'd like to ask the same question to Dr. Tuan.
Yeah, we also have the new SI recently, and we are on our training time. So I think for pancreatic surgery, robotic pancreatic surgery is more convenient than laparoscopic PD, because especially when you do the reconstruction, I think that the robot will help a lot. And the problem is the price as well. And Dr. C.N. Tang is very lucky that the patient don't have to pay anything. But in our country, the patient have to pay more extra fees if the surgery is done by robots. But I think it's very interesting.
Let me just give you a bit of my own opinion regarding robotic versus laparoscopic PD. I think I tried about 50 cases of laparoscopic PD, date back to 2005. And I think the hurdle is not so much for resection. The hurdle is very significant when I think about how to create the anaesmosis. In fact, I got chance to look at some of the great pancreatic surgeons, and they are doing very beautiful reconstruction by laparoscopic approach. But it depends so much what you believe, whether you need to spend a bit of long time and learn the technique and using it routinely for your patient, or whether you've got another tool which can help you to overcome the hurdle, and then you can master the skill a bit faster. And I think this is really debatable, and also depends very much on the situation of the individual surgeon. I started doing robotic PD since 2009. Now I came in about 150 cases. And I think the result, surprisingly, even I believe I'm doing a very beautiful surgery, but surprisingly, the result is not particularly impressive when we compare the open surgery and also the laparoscopic PD. And perhaps there's not comparing the approach, it's comparing the skills of the surgeon. And that would be the confounding factor you cannot overcome completely when you are not doing it in sort of prospective comparisons. And this is the key issue. But I found myself very comfortable sitting in a console. You can also divide your steps, your procedure in different steps, and then to be handled by different surgeons, a sort of pottering and stepwise approach to train up the newer generation. I think this is really more popular in the Western world compared to the Eastern world, but I'm sure, and if the cost is able to be brought down, and there will be more robotic pancreatic surgery in the future.
Thank you very much. It is very good. Even in COVID pandemic, it's very glad to meet good friends. So very good. And I appreciate all the organizing committee, ELSA committee, to make this session. And it's good to meet my friend Xian, also Gore and Taktuan. And is there anything to say to everybody?